All right, thank you, Lisa. Thank you for everybody for being here a little early this morning. As Lisa said, we are very excited for having our first in-person patient education activity for our Northeast section. I'm very excited to start us off here. So we're going to talk about how to engage a team of clinicians with our IBD. So today's goal is to provide an overview of effectively engaging your team of providers in the care of IBD. So in the past, we used to think sort of main issues that we want to be concerned about are how am I feeling today? Fix my symptoms, what is happening now, tailoring my treatment to my symptoms, so sort of current and focus. Now we're moving into something called treat-to-target approach, which is a new way of thinking. So what is my risk of developing complication in the future? Tailoring my treatment to my disease, activity, genetic makeup and risk, and being proactive versus reactive. So our common goal is to treat to target and precision medicine. So treat to target includes improving care and outcomes by targeting specific patient and clinician treatment goals, then monitor the progress towards the treatment goals. What results do the patients and providers want to see happen to improve disease outcomes? Precision medicine is sort of how we get there, and tailoring treatment plans based on individual patients' IBD history, genetics, disease severity, rather than using a one-size-fits-all approach. So the target could look different for different individuals at different stages of life, age, types of disease, whether it's ulcerative colitis or Crohn's disease, disease activity, how active is the disease at this specific time, disease severity, main symptoms, symptoms outside the gut called extraintestinal manifestations, health literacy of the patient, and pre-existing conditions. So when you talk about treat to target and sort of targets we're trying to reach, we can start superficially from the outside with just improving your current symptoms, right? Which is very important and urgent. But then we want to get into discussion with a provider to get deeper into clinical remission, steroid-free remission, mucosal healing, and histologic remission, and what that all looks like. So we're going to talk about some examples of what that looks like and what this all means. So things to keep in mind, we're talking about assessing targets. So again, the sort of the superficial layer of the target would be clinical remission right now only. So associated with the higher risk of flaring and treatment failure compared to mucosal healing or histologic remission if we get deeper. So mucosal healing and histologic remission, this could lead to lower risk of flares, lower surgery, lower use of steroid use, and hospitalizations. So to achieve mucosal healing and histologic remission is just microscopic remission when you take those biopsies during the colonoscopy. This may require long-term immunosuppression, medication that could cause potential side effects too that we need to consider. So what are the treatment guidelines? So as everyone's personal goals, preferences, and targets vary, so will the treatment. So in IBD, it's not always one size fits all. The safest and most consistent clinical guidelines are set by professional societies. This would be the American College of Gastroenterology, or ACG, or the AGA, American Gastro Association. And in inflammatory bowel disease, as all of us do in our teaching with our trainees, there's definitely a lot of art to it. It definitely is not just algorithmic, as I'm sure you're seeing as patients also. So we'll talk about this example of two patients, and towards the end, we'll come back to these two patients and how we could bring together a team to help us with these two goals. So first goal, this patient is trying to reduce steroid use. So you want to taper medication, take smaller doses over time, assess how patient is doing on the clinician side, determining next treatment, and discussing and evaluating next steps. And the second patient, it's time to move on to new biologics. What does that look like to try to reduce inflammation? So we monitor for side effects, evaluate symptom changes, assess mucosal healing, histologic changes, and discuss results and evaluate. So understanding the role of medication does require some help. I just mentioned we have trainees in medicine. These are already full-fledged internists. And we're already working with how complicated these different medications are. And it's fortunate we have newer medications available to us, but with that kind of creates complexities for the providers, the team, and with the patient. So there's a whole host of different medications, aminosalicylates, immunomodulators, biologics, biosimilars, oral molecules that you're seeing more of now for ulcerative colitis, and corticosteroids. So just one example of these therapies would be steroid use. Types of steroids depend on the bioavailability. So how much of the drug is in circulation in your blood. So some of them that have high bioavailability are prednisone, like oral prednisone or IV steroids and methylprednisolone. Low bioavailability are budesonide. This would be like the Entocort type. And then duration of steroids. In general, we do prefer less time, safest time, but less time on steroids as much as possible. Why? Because it can impact body and mental health. There could potentially be serious side effects of long-term steroid use and complication with stopping abruptly. So there's emotional disturbances associated, cataracts, gastric ulcers, potentially compression fractures, osteoporosis. There's a whole host of different potential side effects of steroids when we do not come together as a team with our patients to come up with a plan for a steroid-sparing agent to get to our targets. So on the bottom, you see the little icons that we place in some of these slides. So who are the team members when we're talking about getting on the right steroids, the right time period, and for how long? And then what's the plan after steroids? So the gastroenterologist who specializes in IBD, nurse practitioner, physician assistant, maybe the IBD nurse, and if there's a team pharmacist available, these are the folks who want to engage on the team to talk about steroids and medications. So how about beyond their medical therapy, integrative medicine? So this is bringing conventional therapy, complementary approaches together in a coordinated way. So in addition to medical therapy and procedures, patients often consider diet and complementary therapies to help with their IBD to attain these goals of remission. So diet may improve symptoms and inflammation, and sometimes it can be used as a therapy for IBD. Complementary therapy are part of your IBD comprehensive health and wellness. So with that, at the bottom, for the team members, you do want to engage to help with diet and other complementary therapies. You want to add in registered dietitian, mental health experts into the discussion. So what are some measured targets we want to look at? So we look at endoscopic procedures, radiologic scans, diagnostic and predictive markers, and we'll get into some of those examples. So for endoscopic procedures, we look at colonoscopy, probably the most common, sigmoidoscopy, which is a shorter colonoscopy, upper endoscopy, pouchoscopy if you had a colectomy or colon removed for severe refractory ulcerative colitis, video capsule endoscopy or pill cam, and small bowel enteroscopy to get further into the small intestine. And for those, that's where you partner with your GI physician. Radiologic exams, this is where the radiologist comes into play. X-rays, barium studies, which we don't use too much anymore. Cross-sectional imaging like CAT scan or CT enterography just gets some more details into the small bowel, especially in Crohn's disease. I'm looking for abscess or infection, I should say. And then MR, which is similar to CAT scan, but doesn't have the radiation. And then bowel ultrasound. In Europe, that's very common in looking for bowel thickness and especially Crohn's disease, but even in some other modalities. And it's starting to make an impact here in the US. So again, the GI physician and the radiologist are your key team members in this. So what are these diagnostic biomarkers we're talking about? So these are markers that can assess inflammation and optimize therapy. So biomarkers are characteristics of your body that can be measured. So in IBD, there are a few of them that we measure on a routine basis, usually every 3 to 6 months, depending. So C-reactive protein is a blood test for inflammation. That can happen in the gut or anywhere. So if you have arthritis and ulcerative colitis, say, it could pick up both of those types of inflammation. Same with the SED rate or ESR. That's why we have these fecal markers. So in the stool test, calprotectin, a little bit more specific to inflammation coming from the gut, from the colitis or Crohn's. There's also something called therapeutic drug monitoring. These are these labs that you see in terms of, sometimes there's something called TPMT, which is an enzyme that we check before starting, if we're starting cisplatin or other thiopurines, azathioprine. And this is really to check, to make sure we have the right dosing for safety reasons and for efficacy. And then cisplatin azathioprine turns into these other byproducts, or these products, 6-TG or 6-MMP, just to be technical, but we could actually measure those in the blood also. And then there's other just things that are more recent that are available to help us personalize our care, the specific genes, the HLA-DQA1 is one example of where we're heading towards, where we could try to personalize care. In patients on infliximab or adalimumab, some of these what we call monoclonal antibodies or biologics, some patients, their body can make antibodies against them. You may experience that yourself with some of these molecules. So there are assays that could give us a hint to would you be predisposed to having those antibodies formed. So maybe have a closer look at those antibody levels, which we could check along with the level of the drug itself on a regular basis, or consider other mechanisms of action for your IBD. So how about prognostics or predictive biomarkers? So biomarkers that characterize types of prognostics of IBD, there's just sort of basic here. So P-ANCA, ASCA, CBER, these are just sort of technical terms, things that we could test in the blood to give us an idea. This is more like ulcerative colitis versus Crohn's, more severity. We don't use these too much, but you may see these in the drug test panels. The reason why we don't use them too much is because there are a lot of patients who could have positive P-ANCA and not even have inflammatory bowel disease, Crohn's or ulcerative colitis. But sometimes we do have patients coming into our office with a positive test, say P-ANCA, and say, do I have ulcerative colitis or not? And usually we have to complete that evaluation with a family history and usually with a colonoscopy. But these are just some things, some tools that are out there to give us an idea of prognostics and for disease determination, sort of characterization. There's other more advanced one, IBD-X or Monitor. These are other ones that can help evaluate, and again, if it's Crohn's, ulcerative colitis, and so the level of inflammation. Some of these panels, these are blood test panels that can provide information. Even they can include calprotectin, like we mentioned, other biomarkers of active inflammation. So these are just some of the tools, and there'll be more coming out. So again, this is when you're thinking about these types of tools, you do want to engage your IBD gastroenterologist, nurse practitioner, physician assistant, nurse. So reaching a missing target. So what if my target is not reached? So what are my options? So if you want to review external factors, diseases that may be impacting how well my treatment may be working or not working. For example, some patients with IBD, inflammatory bowel disease, could also have overlap of irritable bowel syndrome also, or functional diarrhea. So we have to consider these different factors or stressors in life that may be contributing to maybe the diarrhea that may be not associated specifically with colitis flare, and that has to be treated itself. Adjusting treatments and continued individualized approach. And we want a target that potentially can be modified if currently available treatments are insufficient to achieve the goal. So again, we want to engage the team. Occasionally, usually every 6 months or so, we have our routine office visits, but even outside of that, through messaging, depending on the patient portal they have available to you, to make sure we're on track with these targets. So there's a group called IBD Chorus, which is a quality improvement initiative by the Crohn's and Colitis Foundation. There's 50 sites across the country. We're a part of that. Yale's a part of that. Brown, Connecticut GI are part of this consortium to help improve quality care in IBD. And there was a survey coming out from this group of patients, 100 patients, look at the top goals and concerns reported by individuals with IBD. And they categorize these into 4 categories: symptoms, psychosocial and quality of life, clinical course and management, and medication. So in terms of symptoms, their main concerns were maintaining levels and prevent future symptoms, and improving disease control. Specific symptoms mentioned were pain and urgency, like sort of rectal or fecal urgency, feeling like you need to go, but not diarrhea necessarily. Psychosocial and quality of life, so work or travel or work, those are some of the main concerns. Emotions, fear and worry were the main 2 emotions that we were seeing as a concern for our patients with IBD. Clinical course, family planning, nutrition, management, access to care. I think that's a big one. I'm surprised I didn't get more numbers on there. I think on the provider side, we see a lot of problems with access to care, unfortunately, especially when it comes to medications. And that could be clumped into insurance and costs. And then medications, side effects, or lack of efficacy. Those are all very real concerns. That's something we need to have discussion with our care team. And then biologics tend to be most mentioned. And then again, to immunomodulators, those 6-mercaptopurine or thiopurine, azathioprine type of pills. So how do we effectively partner? So the goal setting and effective partnering. So effective partnering is pretty much setting up your goals alongside your healthcare provider, discussing your personal preferences, and talking about short-term and long-term goals, improving quality of life and healing for the future, not just the present. So you must have the understanding that we aim for the best possible outcome, but of course we can't achieve 100% of that all the time, unfortunately. So another definition out there, what is shared decision making? Patients are actively involved in their medical decisions, opportunities for patients to be informed about their treatment options, being active in determining their treatment plans. But most patients with IBD and physicians who see a lot of IBD, by 80%, prefer a more of a shared decision-making approach versus the physician just telling them what medication they should be on, or vice versa. Benefits of this approach: increases treatment satisfaction, confidence in treatment choice, and may improve treatment adherence. So as we slowly wrap up here, so how to engage in shared decision-making. So you want to have an open, honest communication with your medical team, but this is not always easy. You understand, I mentioned sometimes you do need to use the patient portal. When you have your first visit, or your first couple of visits with your IBD physician or their team, you want to make sure you understand, or they're very clear with you in terms of what's the best form of communication. If I have flare, how do I take care of that? Who do I call? Who do I message? Or medication issues, or insurance issues, or scheduling for procedures. So you want to really get that up front or in the first couple of visits. You want to practice talking about difficult topics with a friend or family member before your appointment, ideally. Make notes of important questions or thoughts about your treatment and bring them to your appointments. If you're not sure of your ability to communicate, bring a friend or family with you if that's something that goes along with the rules of the clinic or the hospital. Recognize there is more than one right way. So going back as we summarize to those patients, so goal number one for that patient is to reduce steroids. So this is a discussion of certain tapering steroid techniques. So how low are we gonna go, how fast are we gonna go with the steroids, review the risks and benefits of decreasing steroid use, and together determine the next therapies or treatment options. And for the other patient, to try to new biologics to reduce inflammation, you want to have the discussion on how to monitor for side effects, share with your provider any symptoms change, experience, and then test and evaluate for mucosal histologic change. Remember, this will be the colonoscopy, and discuss all results with your provider. So you may have seen some of these resources on the table out back, but there's Crohn's Colitis Foundation provides a lot of these resources online and paper form, the IBD symptom tracker, the discussion guide. So these are just tools that can help us have the conversation with our providers when we do either message our providers or have that meeting in person or virtual. So in summary, to treat to target is a strategy where the IBD care team and patient decide on a plan with the aim to achieve a set goal within a specific time period. Goals are different for each patient based on his or her diagnosis and personal circumstances. To achieve the goals, the healthcare team will check to make sure the patient responds to the initial strategy at timed intervals. And these checks may be blood tests, stool tests, colonoscopies, radiology exams. If there is not sufficient improvement, additional workup or evaluation or treatment adjustments may be advised. And you want to set goals alongside your healthcare provider, both for the short term and the long term. Thank you.